Dear audience, let me present my PhD research about extraintestinal manifestations in inflammatory bowel disease. My name is Ágnes Tímár. I'm a PhD student and a pediatric resident at Heim Translational Pediatric Institute. My supervisor is Katalin Müller, and my SMS is Mark Ernátfői. I have a vision to improve the quality of life of IBD patients through proper treatment, and to achieve that, my mission is to assess long-term disease outcomes and treatment options of IBD patients with extraintestinal manifestations. I have two ongoing projects. In the first one, I investigated the effect of different advanced therapies on extraintestinal manifestations, conducting a meta-analysis. And my second project is a registry analysis about the relationship between extraintestinal manifestations and the intestinal disease scores in children. So let's start with the first project and its importance. During the advent of anti-TNFs, they have been proven to be effective in IBD and revolutionized its management. However, 1/3 of the patients experience loss of response within 3 years, and in these cases, several new drugs are available. There is a vulnerable group of patients among the IBD population, approximately 10–25% of them who will develop extraintestinal manifestations. These patients face a greater challenge in their daily living due to greater symptom burden, higher peer burden, and impaired quality of life. It is a frequent misconception that the successful treatment of the intestinal inflammation will be always sufficient to treat extraintestinal manifestations as well. Therefore, it is highly important to adapt the treatment in a way that it will cover extraintestinal manifestations too. So I would like to highlight our treatment options very briefly. We have ustekinumab, tofacitinib, and ufalacitinib, which all have a systematic effect and are already applied in other immune-mediated diseases. And on the contrary, there is vedolizumab, which is a gut-selective drug that blocks the T cells from entering the GI tract. Therefore, it is expected to have less effect on extraintestinal manifestations, but it has a more beneficial side effect profile. And our aim was to determine which of these advanced therapeutic options is associated with the lowest frequency of extraintestinal manifestations. So we investigated IBD patients who received a kind of advanced therapy, and our primary outcome was new extraintestinal manifestations, and the secondary ones improvement and worsening of already pre-existing extraintestinal manifestations. We hypothesized that the frequency of extraintestinal manifestations will be the highest in patients who are on gut-selective biologicals. We conducted our systematic search on the 15th of November in 4 databases, which resulted in more than 13,000 hits. During the selection process, we were able to reduce it to 61 eligible articles. So let's proceed with the results. In general, in all of my forest plots, proportion was used as measure of effect, and subgroups were formed based on the applied drug type. So this figure shows the proportion of all new extraintestinal manifestations together during advanced treatment. And as I mentioned before, we hypothesized that the proportion will be the highest in the vedolizumab subgroup, and indeed we found a higher prevalence rate. However, the difference did not reach statistical significance. As extraintestinal manifestations are really distinct diseases, we decided to analyze them separately as well. So this plot shows new joint, new skin, and new ocular manifestations. Here you can see that the difference between vedolizumab and ustekinumab treated patients were neither statistically nor clinically relevant, as the occurrence rates are quite similar. Upon moving to our secondary outcomes, which were change in pre-existing extraintestinal manifestation, these two plots show improvement and worsening of pre-existing joint manifestations. And here we can see that improvement rates are significantly lower in case of the vedolizumab-treated patients compared to the ustekinumab subgroup, whereas worsening rates are significantly higher in the vedolizumab-treated patients compared to the ustekinumab-treated patients. Due to the lack of time, I can't show all of my forest plots, but this is a table of all of my investigated outcomes. Here I would like to just highlight that there was only a significant difference in case of improving arthralgia, which is a type of joint manifestation which was detailed before. So the biggest strength of my study that we were able to include a relatively high number of studies which were published in the last 5 years, and we were able to provide a detailed subgroup analysis and meticulous methodology. However, there are several limitations as well. For example, there are no RCTs available in this topic, and we had to face really heterogeneous follow-up times and non-standardized reporting system for extraintestinal manifestations in the different studies. In conclusion, we can say that new extraintestinal manifestations are rare and there is no difference in the occurrence of them among advanced therapeutic options. And the worsening of joint involvement was significantly more common in case of vedolizumab therapy. The improvement rates were significantly lower. So we suggest not to under-prioritize vedolizumab in cases of pre-existing extraintestinal manifestations, except where joint involvement is already present. And we suggest to come up with a more standardized reporting system, and also we need more prospective registries with detailed information about extraintestinal manifestation and these new advanced therapeutic options. I submitted my manuscript to the Journal of Crohn's and Colitis in July, and it is currently under review since the end of July. In the remaining time, I would like to show my second project, which is a registry analysis, as I mentioned before. Extraintestinal manifestations are common in pediatric IBD. Approximately 25–40% of the patients will develop at least one during their lifetime. However, little is known whether these patients experience more severe intestinal disease course. And we found a recent meta-analysis which showed that these patients have a higher risk of undergoing IBD-related surgery and biological therapy. However, this meta-analysis included studies mostly with adult patients, so we are interested whether the situation is the same in the pediatric population. There are already some suggestions in the literature that early aggressive therapy could prevent long-term complications. So our aim was to provide a descriptive analysis of the frequency of extraintestinal manifestation among Hungarian children based on the Hungarian Pediatric IBD Registry, and to analyze the association between the presence of extraintestinal manifestations and the intestinal disease course. So we will investigate pediatric IBD patients and compare those who present an extraintestinal manifestation already at the time of diagnosis and those who develop the first one during the follow-up time with those patients who have no extraintestinal manifestation during their follow-up. Our outcomes will be relapse rates, therapy failure, surgeries, and steroid dependence. We hypothesized that these patients have a higher risk of poor prognosis of IBD, and we plan to define the role of extraintestinal manifestation as a prognostic factor so that these patients could benefit from earlier treatment escalation. And this is where we are right now in the progress. We received the descriptive statistics and the analysis is currently ongoing. This table is here just to give a quick insight what numbers we are dealing with. So there are more than 2,300 patients in the registry, out of which approximately 350 have an extraintestinal manifestation and diagnosis, and another 85 developed one during their follow-up time. So this is the summary of my two projects. I submitted the first one in July and then plan to submit the second one in November. I would like to finish my presentation with a quote that the best preparation for tomorrow is doing your best today, and thank you for your kind attention.
Were you able to analyze the population based on only just the Western studies, and could you explain the population of these studies?
Yes, so a lot of the studies were conducted in the United States, and the other half is conducted in Europe. Yeah, mostly in Western countries, but some were conducted in Turkey, as I remember, and Israel, which is also a developed country as well. So I know that maybe you asked that because these are expensive drugs, or but yeah, these aren't really available in the other countries.
you're talking about extraintestinal manifestations and how they react on a treatment which is given to make their gut disease better. Have you made a point that they are equally good from the gut's point of view? Because I think that's the starting point to say they are equally good for the disease. You prescribe these drugs, but one of them or a few of them could be better for certain extraintestinal manifestation. I don't think you can take apart the main therapeutic effect and the additional benefits. I think that was the point which I missed a little bit from your presentation, but very, very nice work. Thank you.
Yeah, thank you for your suggestion.
This subgroup, the very early onset IBD, is there any difference according extraintestinal manifestation? These two groups, very early onset and after that?
Yes, so the thing is that my first project is not only about children, it's about, so most studies were conducted on adults because of these drugs, so it is a mixed population. I believe that there was only one study with very early onset IBD, so I can say for sure. Regarding your second project, in that project, do you plan to analyze the different extraintestinal manifestations separately? Yes, thank you for your question. Definitely, we plan to, I believe we have enough data for joint manifestations and primary sclerosing cholangitis and the skin manifestations as well. So we plan to analyze them separately as well.
What is the average follow-up time in the registry?
Yeah, thank you for your question. It is 2 or 3 years, and it could seem to be short, but mainly these patients are diagnosed at the age of 15, 16, so they transition to the adult care. That's why it is so short.